Actually, we go on to our next video by Dr. Rahul Shukla, who's a senior consultant in the Department of Cataract and Refractive Surgery at the SHUKLA Eye Hospital, Jabalpur, another very dynamic young surgeon, and he's going to be showing us an interesting case. On to you, Dr. Rahul.
Thank you so much, ma'am. I think my video is already uploaded. I would request Shiragji to start the video, please.
Good afternoon, everyone. At the outset, I would like to thank Chairman ARC for giving me this opportunity. I'll be speaking about CCC in intumescent and mature cataracts. As we already know that intumescent and mature cataracts have high intralenticular pressure, that's the intracapsular pressure, and a cohesive OVD helps in reducing that pressure over a very small central area by displacing the semifluid cortex from the central area, thus giving us this opportunity to get a small sized initial rhexis. A two-step CCC is the most accepted norm, a heavy OVD with a small central rhexis followed by debulking of the semifluid cortex and enlarging it. Many use a 26 gauge needle to puncture the capsule and aspirate the semifluid cortex. Others use a phacorhexis to create a small hole in the capsule. The importance of debulking is clearly shown in this video that if you have not debulked it properly, use a heavy OVD, use the Brand-Little maneuver of pulling the CCC edge towards the center, still it goes out. I present a different technique to debulk the semifluid cortex, thereby further reducing the chances of urgent inflaction. After injecting a heavy OVD, Helon GV preferably, as it works better. And this is a slow motion of wherein I'm catching the edge of the capsule as close to the rhexis margin, and I'm pulling it towards the center and creating a very small CCC in the center. With the phaco probe in the aspiration mode and with the collar button dialer, I actually gradually go in and try and aspirate as much as cortex as I can. And in that process, I just use the tip of the phaco probe to dial the nucleus. That way what happens is, and I keep on compressing the nuclear pieces. That way all the fluid cortex comes out, and if at all there is any kind of obstruction, I use the dialer. As you can see, things come out. Once I have done that, I inject the OVD, enlarge the rhexis. It's a cakewalk now. So essentially, debulking is paramount. And I would again show another video similar to the ones which I've shown prior to this. Now the best part with this is even the dialing of the nucleus is possible. Again, once I've done the central CCC, I keep on debulking it, try and move the nucleus, and I am able to dial the whole nucleus. And once I am dialing it, the semifluid cortex which is attached, which is stuck, and mind you, these cortexes wouldn't come out either with a 26 gauge cannula or any other maneuver. It's only the dialing that would disengage that cortex, and that disengagement is paramount. And with the aspiration mode, I am able to suck in all the cortex. I am stationed right in the center, and once the whole thing comes out, it becomes easy for the rhexis to be enlarged. So what was known is that the high intralenticular pressure leads to urgent inflaction. Debulking of the fluid cortex is the way forward, and 26 gauge needle puncture and aspiration of the fluid cortex helps in the controlled CCC. A few use phacocapsulotomy. While improper debulking, and what this video adds is improper debulking leads to runaway rhexis using a greater collar button hook and phaco probe in aspiration mode that helps in near complete debulking of the fluid cortex. Thus extending the rhexis is more controlled, and it further reduces the chances of a runaway rhexis. So this is my pearl in cataract surgery for today. Thank you so much for your patient hearing.
Thanks, Dr. Rahul. That was a wonderful tip which you showed us, but we need to argue it out. I felt that if in a small rhexis, if you have as you this, instead of using a phaco probe, which could have a more deleterious effect, could an IA have been used? Dr. Arun, I wanted to comment on it. A decompression could be done with an IA probe too, instead of using a phaco probe. And what are your thoughts? Of course, he said he keeps the phaco probe right in the center, doesn't move it to the periphery. But having said that, it's a small rhexis. What are your thoughts?
My preferred technique is to use an IA probe only. I use an IA to debulk the cortical matter. And most of the cortical matter is very fluidic or even it comes very easily with the irrigation aspiration. You really don't need a phaco probe to debulk the cortex. And that's good enough. Then you can go ahead with your secondary rexes.
And of course, Dr. Mohan had already said that the punctorexis is another option which could be done, which is again open to the same risk as what could be there in Dr. Rahul's case also. Just a burst of phaco, and even you use a little high vacuum and flow rate. I don't think punctorexis is 100% safe in all of these increased intralenticular pressure. Your thoughts, Mohan?
1 point, ma'am.
Yes, yes.
You're asking the wrong person about punctorexis.
I know.
Yeah.
Yes, Dr.
Punctorexis. No, there is a learning curve on
actually,
punctorexis.
yeah.
Please understand, don't use Elon, don't use viscode, just use simple HPMC. Just go vertically down. If you go tangentially, then you will have an Argentina flag sign. I really like Rahul's because he's debulking, but he's using a phaco probe to debulk. Okay, only thing is a little amount of trench in the center also will debulk the nucleus, also push the nucleus back. And because it's a larger needle, larger bore needle, phaco needle, it can aspirate the fluid from behind the nucleus also. And he's able to rotate it and push the nucleus back. And then you can extend it. Then after that, it becomes a cakewalk. Only thing I would refer with Rahul is when he was making the first initial rexes, you did it through the main port. If you notice carefully your videos, the viscoelastic is coming out because you're using I think Utrecht forceps for that, and always go through the side port if you want to go to or use a micro rexus forceps through the side port, because you don't want the viscoelastic to come out of the eye when you're making that small rexus, because you can go and have an Argentina flag sign even at that stage. So
yeah,
I would,
so let me answer a few questions here. As rightly said, yes, an IA probe would be much more better. But an IA probe, if you use a single IA probe, is going to give you the same amount of bulkiness which is there. And there are chances of you catching the rexus margin again with the tip of the IA probe. So this is one thing. With the phaco probe, the needle down, and as the collar button hook dialing the thing, you keep on getting the fluid inside the phaco probe. So yeah, you can always use a bimanual probe wherein you have irrigation from one port and the aspiration from the other. But this time, as you try and go inside, you actually have to go inside the rexus. You have to go below the anterior capsule. That is one time you can actually tent the anterior capsule again, and the runaway rexus could again occur. So we don't want to actually touch that. So this is one thing which I tried a lot. I have failed a few times, but then yes, as Dr. Mohan Rajan rightly said, there's a learning curve to it. But then if you can do that, I've been doing it since the last 3-4 years now, and I'm pretty confident now. But yes, initially I was not very confident. Second is the side port. Yes, as Dr. Rajan said rightly, the side port is obviously going to be better. But then since I'm sitting temporarily and I have got the main incision, I started doing it, and a Helon GV or a Helon 5 works very well here. It actually stays there wherein it is required to. You need the central area. What basically I just want to stress on this video is that you need to know your physics very well. There are two forces, centripetal and the centrifugal forces, number one. And second is the intralenticular pressure needs to be less than the extralenticular pressure. The pressure outside the AC needs to be more. How do you do that? You just make sure that you have a heavy OVD to it. But even after that, even after that, you've created a small CCC, there is going to be the side cortex, the semi-fluid cortex, which is going to make sure that if you are not removed it, it's going to give you that runaway rexus. So the take-home message is the debulking is paramount even after you have successfully done a small rexus. Yeah, you have different modes to do it. You can always use a 26 gauge needle. I mean, this is the most used, I think, instrument. Second is obviously you can use an IA probe. I am comfortable in the phaco probe.
Yeah, very nice, Dr. Shukla.
Sorry.
Can I move on to the next video? There are many more interesting videos.
Yeah.
So I'm sorry.
Just 1 point, ma'am.
Yes.
The one observation that I made, very nice video by Dr. Rahul. The ergonomics of a phaco handpiece is very good to aspirate the liquid cortex. And one point that I noticed is that his sleeve was ahead of his tip. So that is very gentle to the anterior capsule. So the chances of breaking the anterior capsule were very less. I noticed that the sleeve was ahead of the phaco tip.
Yeah. I forgot to mention that in the video also, because
please make sure that your phaco tip is not in the same plane as the capsular rexus.
That's
You have
true.
to be a
Going
little
down.
posterior. You
It
have
has
to
to
go a
go
little down. Then
Yeah.
only then you'll be able to aspirate. Similarly, for
Yeah.
puncture rexus also, go bevel down. If you have 15 degree, I use a 15-degree tip, go bevel down, go vertically down. Don't go tangential, go vertically down as if you are going into the anterivitreous. And then you punch.
I
But
failed to
with
mention
sleeve-
that my sleeve is
Yes.
so far forward that the edge of the bevel,
Correct.
it actually is at the edge of the bevel, the backward bevel, it is at the edge of that. So you hardly have any exposure of the tip.
Tip.
Yeah, I'm going to move on to the next video. Wonderful, Dr.